Good afternoon. My name is Motaz Qadan, and it gives me great privilege today to be able to provide this presentation, and my apologies that I could not be there in person. Today, I'm going to be talking about prehabilitation pathways, who, how, and when. And of course, I will provide this with the context of pancreas cancer, given that this is my area of expertise. I have no disclosures to report. So going through this prehabilitation for pancreas cancer, I'll give you a little bit of information and background to start with. So pancreatic ductal adenocarcinoma, as many of you know, is the fourth leading cause of cancer death in the United States. And according to SEER data, 5-year survival rates for all stages between 2008 and 2014 were only 8.5%. Now, PDAC impacts multiple components of patients' health, including their cardiopulmonary fitness and nutrition. And what we do know is that nearly half of patients with PDAC have cachexia at the time of their operation, and this is associated with decreased skeletal mass, what's known as sarcopenia, physical activity, and overall survival. In fact, patients with PDAC often experience malnutrition due to the disease process and the side effects of the treatment, and this may impact patients' physical fitness, ability to safely tolerate surgery, and their post-operative recovery. What we also know is that advances in chemotherapy have led to a paradigm shift in the use of total neoadjuvant treatment, where we give all the chemotherapy and even radiation up front at this point. But that itself is complicated by toxicities, including anorexia, nausea, diarrhea, dehydration, and fatigue. And this neoadjuvant therapy may even exacerbate issues with malnutrition and can lead to progressive weakness and major deconditioning, but can also cause cardiopulmonary toxicity, which impairs aerobic capacity. What we also know is that patients' preoperative fitness levels are predictive of their postoperative outcomes, and that an individual's aerobic capacity predicts preoperative functional reserve. Additionally, patients' aerobic reserve has been shown to inversely correlate with post-op morbidity. And so we know that patients with poor baseline physical fitness are more likely to have a prolonged recovery and even never return to baseline levels. What we know with respect to nutrition is that studies involving nutrition counseling, the certified dietitian, and intake of oral supplements demonstrate the potential to improve patients' functional exercise capacity, and that the goal of a nutritional prehab program is not to reverse longstanding nutritional deficits, but to optimize the patients for the catabolic insult of the perioperative period. So one of the first studies that we embarked on was to look at patients who underwent TNT therapy at MGH to examine the role of sarcopenia and how this correlates with their outcomes. And we looked at changes in body composition at the time of diagnosis versus immediately pre-op. So that gives us an opportunity to examine the role of this neoadjuvant therapy period. And then we correlated these changes with postoperative outcomes. And there are 164 patients who we retrospectively reviewed who had undergone neoadjuvant therapy between 2013 and 17. And we examined the skeletal muscle area, SMA, at L4. And we noted that 38% of patients had lost greater than 5% of their muscle mass, and 27% had lost greater than 8%. In fact, both of those parameters were associated with a 2-year overall survival decline, ultimately, that was associated with the sarcopenia. And so what we know is that we have patients who now have a disease process that is obviously going to affect their outcomes and well-being, chemotherapy, which will exacerbate this, and then they're about to undergo a major pancreatectomy operation, such as Whipple. And all of these things result in a debilitated patient. And so patients are now arriving at the operating room probably in the worst shape possible as a result of these treatments and their disease process. So with respect to prior studies of prehabilitation, these have been limited by small sample sizes and mostly focused on unimodal intervention. And despite being underpowered, prior studies have still shown a decreased length of stay, ICU stay, and post-op complication rates. And so a critical knowledge gap remains regarding the use of implementation of prehabilitation interventions, specifically for patients with pancreas cancer whom I'm interested in. This is an important trial. I actually bring this up as probably one of the bigger trials that's around, where the investigators of this trial aim to assess the impact of personalized prehabilitation on post-op complications. This is actually a high-risk patient population greater than 70 years of age who are ASA 3 or 4. And the intervention here included high-intensity endurance training and physical activity with examination of postoperative outcomes. 125 patients, 62 were in the prehab arm, and the authors were able to show a reduction of 51% of complication rate. And you can see here that the biggest benefit of this trial is shown on postoperative complications. And so at MGH, we decided that a structured prehab intervention in the preoperative period may improve patient tolerance to both the neoadjuvant therapy and the surgery. And then the interval between the time of cancer diagnosis and scheduled operation provides this unique opportunity to optimize patients by improving their endurance, skeletal muscle mass, and nutrition. And that prehabilitation may enable patients to preserve their physical fitness during the neoadjuvant therapy and thus arrive in better shape for surgical resection. And so I'm delighted to report that we do have a pilot study now of multimodal prehabilitation that is listed here on clinicaltrials.gov. And going through the hypothesis and aims, our hypotheses were that the intervention would be feasible to deliver and acceptable to participants defined by perceptions of usefulness, effectiveness, and relevance of the intervention. And we believe that 50% of patients with localized PDAC will enroll and complete the multimodal prehab intervention. And so our aims are to conduct a prospective pilot study to assess the feasibility of delivering this treatment, to determine the acceptability of the intervention for patients and clinicians, and to assess clinical and biologic outcomes for patients who receive the intervention. And our study design, this is obviously a prospective single-arm feasibility pilot at this point, a phase 2 study. And we set out to test the proposed prehabilitation intervention by conducting a single-arm pilot in patients aged 18 years and over without metastatic pancreas cancer. In the description of the intervention, as you can see here, probably the most important slide here is it shows you how this exercise and nutrition intervention occurs during that period of neoadjuvant therapy. And we see our patients for an initial visit and then multidisciplinary visits for a total of 16 weeks of chemotherapy, followed then by chemoradiation, followed by a brief hiatus of approximately 4 weeks, followed then by surgery. And during these intervals, we have patients set up to come back and see us for their multidisciplinary visits and scan reviews. And so we made sure that the prehab program actually fits in very nicely with those visits to ensure it's very nicely coordinated and imparts minimal burden on the patients. You can see here the components of this include the exercise tests, the labs, the CT scan, where we actually measure skeletal muscle areas, as well as stage the patients, and the questionnaires. And so the components of the intervention, we have a fitness program, a 20-point fitness assessment at initial visit, and then patients are placed in one of 3 tiers because they come in different shapes and sizes, including here a basic, intermediate, and advanced tier, and then group exercise sessions twice per week for duration of the program. So that's a total of 26 weeks. And then we have a meeting arranged with a nutritionist within 4 weeks of enrollment, and patients undergo whey protein supplementation of 1 gram per kilogram 4 times per week with a logbook, but also are aided with symptom management during their neoadjuvant therapy, since many of these symptoms can be nutritionally related. And this is a photograph of the gym that we have in our Newton Wellesley Hospital site that we use in collaboration with our site. And you can see here with specialized physiatrists who help with patient exercises and are actually specifically trained to work with cancer patients. And then in terms of data collection, so we had no prior data to go on, but prior reports had suggested completion rates of 40 to 80%. And we anticipated patient dropouts related to the length of the study, as well as patient withdrawal due to this particular disease process and progression in pancreas cancer. And so our primary outcome was that at least 50% of participants would complete 50% of the components of the prehab program. And then we have a whole battery of secondary outcomes, including, as you can see here, feasibility, patients who agreed to participate, completing the exercise measures, completing the nutrition measures, the disease outcome measures, the patient-reported measures, and the objective stress assessment measures. Acceptability, including ratings from patients, family caregivers, and clinicians, as well as exit qualitative interviews with patients, family givers, and clinicians. Patient-reported outcomes, including a lot of these validated surveys that are listed here. Cancer outcomes, specifically the number of chemotherapy cycles that are completed, FOLFIRINOX in our institution, the number of treatment delays, the cumulative doses of chemotherapy received, but also pathology results, including surgical R0 resection rates, node positivity rates, and pathologic complete response rates. Then we have surgical outcomes that are standard: tolerance of diet, adequate pain control, return of bowel function, 24-hour fever-free period, mobility, discharge from hospital, and then readmission rates and complications, and then also 30 and 90-day mortality. We have exercise outcomes. Again, many of these are validated and already used in other studies. Nutrition outcomes, and importantly here, including the PGSGA, again, validated outcomes that have been previously reported. Disease outcomes, including changes in systemic markers of inflammation and body composition throughout the study. And we're even storing blood from all those patients so that we can have those samples available in case we go back and study changes at the molecular level that are imparted on patients by the prehabilitation program. Now, unfortunately, we took a little bit of a hit during COVID-19, and the gym remains closed at this time, especially with rising cases now of the Delta variant. But we are hopeful that we will open at some point in the near future. I'd like to give credit here to Dr. Naomi Sell, who's one of the excellent residents who I've had the privilege of working with and has pretty much helped with running this trial and making our own project as well, which has been fantastic. In terms of some prelim data, we had screened 25 patients, approached 16, consented 12. And you can see here out of the 12 patients, there were 4 left active participants, 4 had metastasized, and 4 have dropped out, probably because of the duration of the study. And so you can see here, actually, suddenly the 50% even, which we thought would be a generous outcome, starts to look a little bit iffy with these numbers. And just a quick mention that we decided to continue some of the prehabilitation work using telemedicine during the COVID-19 pandemic at its peak in the year 2020. And in response to COVID-19, we used some preliminary trial data to devise a telemedicine prehab program that included exercise intervention, nutrition intervention, but also added in some smoking cessation advice, as well as mindfulness training as well. And so the hope is that this feasibility trial would lead to a randomized controlled trial, and ultimately would be able to come up with a therapeutic intervention that is acceptable and actually billable for insurance purposes that we can implement in all our patients. And I'd like to acknowledge the following individuals, particularly Dr. Naomi Sell, who I mentioned a short while ago, as well as Dr. Keith Lillamo, whose support has been instrumental in this institution at large. Thank you kindly for your attention today.